Hey, what's up guys? We're back with another EMT chapter review. This time we'll be talking about neurological emergencies. In this chapter we'll be talking about the anatomy, presentation, and management of decreased level of consciousness, seizure, and stroke. We'll also be talking about the anatomy, physiology, pathophysiology, as well as the assessment and management of seizure, stroke, status epilepticus, and headache. Now let's talk about some of these terms. Stroke is the 5th leading cause of death in America. And in the Bahamas, the WHO found that it was 10% of our total deaths in 2020. It's most common in geriatric patients, and some of the contributing factors for stroke are race as well as family history. Now let's talk about seizures. Some of the contributing factors for seizures are recent or prior head injury, a brain tumor, metabolic disturbances, fever, or genetic disposition. Then we also have your altered mental status. This can occur due to intoxication, head injury, metabolic disturbances, stroke, or hypoxia. Treatment for all these different conditions may vary. Now let's talk about the anatomy and physiology of the neurological system. Let's start with the brain. The brain consists of 3 parts: the cerebrum, brainstem, and cerebellum. The cerebrum is the largest part of the brain. The brainstem controls basic body functions such as breathing, blood pressure, swallowing, and pupil constriction. The cerebellum controls muscle and body coordination. Now let's look at the cerebrum. The cerebrum is divided into two halves, the left and right hemisphere. Each side controls the opposite side of the body. The front part of the cerebrum controls emotion and thought. The middle part of the cerebrum controls sensation and movement, and then the back processes sight. In most people, speech is controlled by the left side of the brain, near the middle of the cerebrum. Now, messages sent to and from the brain travel through nerves. There are 12 cranial nerves that run directly from the brain to parts of the head. All the other nerves join at the spinal cord and exit the brain through a base opening at the back of the skull known as the foramen magnum. At each vertebrae of the neck and back, nerves branch out. These are called spinal nerves. These send messages to and from the body. Many different disorders can cause brain dysfunction. This can affect the patient's level of consciousness, speech, and voluntary muscle control. It's important to note that the brain is sensitive to changes in glucose, oxygen, and temperature. Now let's look at headaches. It's one of the most common conditions. It can be a symptom of another condition or a neurological condition on its own. Now note, only a small percentages of headaches are due to a serious medical condition. Here we can look at some of the most common types of headaches. You got your tension headaches, you got your migraine headaches, and then you got your sinus headaches. Tension headaches. These are caused by contractions in the head and neck, attributed to stress. Pain is usually described as squeezing, dull, or as an ache. These usually don't require medical attention. Then you have migraine headaches. These are thought to be caused by changes in the blood vessel size in the base of the brain. Pain is described as pounding, throbbing, or even pulsating. This is often associated with nausea and vomiting and can be preceded with visual changes. These can last from several hours, even up to days. Lastly, we have sinus headaches. These can be caused by pressure due to the fluid accumulation in the sinus cavities. Patients may also experience cold-like symptoms such as nasal congestion, cough, and fever. Pre-hospital care is usually not required. Now, there are some conditions that include headache, such as hemorrhagic stroke, meningitis, and a brain tumor. Now let's talk about stroke, also known as cerebrovascular accident. This can be caused by the interruption of blood flow within an area of the brain, which can result in the loss of brain function. There are 2 types of stroke, ischemic and hemorrhagic. Let's talk about ischemic first. This is the most common, accounting for 87% of strokes. This can be caused by a thrombolus or an embolus. Most symptoms can vary from nothing at all to complete paralysis. Arteriosclerosis of the blood vessels is often the cause. Hemorrhagic stroke. This accounts for 13% of strokes. This results from bleeding within the brain. Cerebral hemorrhage are often fatal. People at high risk are those experiencing stress and exertion, and people at the highest risk are those with a very high blood pressure. When you think about hemorrhagic stroke, you must think about an aneurysm. This is a swelling or enlargement of the wall of an artery from the weakening or defect of the arterial wall. Let's talk about transient ischemic attack, or TIA. These are stroke-like symptoms that may go away on their own in less than 24 hours. It's usually a sign of a larger stroke to come. About 1/3 of patients who experience a TIA will experience a stroke. So now that we describe what a stroke is, let's look at some of the signs and symptoms of stroke. These include facial drooping, sudden loss or numbness in the face, arm, leg, or one side of the body, decreased or absent movement and sensation of one side of the body, lack of muscle coordination, ataxia, or loss of balance, sudden vision loss in one eye, blurred and double vision, difficulty swallowing, decreased level of responsiveness, speech disorders, aphasia, slurred speech, sudden and severe headache, confusion, dizziness, weakness, combativeness, restlessness, tongue deviation, and coma. Stroke can happen in both the left and right hemisphere. Stroke in the left cerebral hemisphere can cause aphasia. This is the inability to produce or understand speech. Stroke in the left hemisphere can also cause paralysis of the right side of the body. Now, stroke in the right cerebral hemisphere can cause paralysis in the left side of the body. Patients may not even know that they have a problem. Now, this lack of pain and neglect of the problem may cause patients to delay seeking help. Let's talk about bleeding in the brain. Patients may have high blood pressure. This can be the cause of the bleeding, or this can be the cause by the bleeding. Increasing blood pressure is an important sign. Also, significant drops in blood pressure may be a result of the condition worsening. There are some conditions that does mimic strokes. You have hypoglycemia, post-ictal state, as well as subdural or epidural bleeding. Now let's talk about seizures. These are neurological episodes caused by the surge of electricity in the brain. These can take the form of a convulsion and/or temporary alteration in consciousness. There are two groups of seizures. You have your generalized seizures, and then you have your partial or focal seizures. Generalized seizure. This is a result of abnormal electrical charges from large areas in the brain. It's usually characterized by unconsciousness and generalized severe twitching of all muscles, usually lasting between several minutes or longer. Absent seizure. This does not involve any changes in motor activity. This is characterized by a brief lack of consciousness in which the patient stares in a blank state. Moving on to partial or focal seizures. First, we'll have to talk about focal onset aware seizures. Now, the patient may have no changes in level of consciousness, but the patient may experience numbness, dizziness, weakness, visual changes, or unpleasant taste or smell. Patient may also experience twitching or brief paralysis. Moving on to focal onset impaired awareness seizures. The patient will have altered mental status, and this is a result of abnormal discharge from the temporal lobe of the brain. This can cause lip smacking, eye blinking, isolated jerking, unpleasant smells, visual hallucinations, as well as repetitive physical behavior. Another key term we want to talk about is aura. This is the feeling that patients feel like a warning sign before a seizure. People with histories of seizures may experience their own auras and take measures to minimize injury. Now, not all auras occur before a seizure, and not all patients with seizures may experience auras. I mentioned the term earlier, status epilepticus. Now, seizures lasting for 5 minutes or longer will usually result in status epilepticus. And our status epilepticus are seizures that last up to 30 minutes or longer, or as well as seizures where persons go in and out of seizures every few minutes without regaining consciousness. Another term I mentioned earlier was post-ictal state. After a seizure, the muscles become relaxed and the patient's breathing becomes labored. This can be characterized by hemiparesis, or the paralyzation of one side of the body. Now, this is most commonly characterized by patients with lethargy or confusion. And if the patient does not improve, consider possible other underlying conditions. We also mentioned earlier altered mental status. Aside from seizures and stroke, this is the most common neurological emergency. Patient is not thinking clearly and is incapable of being aroused. In some cases, the patient is unconscious. In other cases, the patient is alert but confused. Now, let's look at some causes of AMS, or altered mental status. Hypoglycemia, hypoxia, intoxication, delirium, drug overdose, unrecognized head injury, brain infection, body temperature abnormality, brain tumor, overdose, and/or poisoning. Moving on to the management of neurological emergencies. First, the scene size up. Make an early determination if the cause is medical or trauma. Look for safety threats. Follow standard precautions. Consider the need for spinal motion restriction and call for additional resources as early as possible. Next, you have your primary assessment. Look for life-threatening conditions. Perform a rapid exam. Also, establish priority care based on your level of consciousness, as well as bleeding, airway, breathing, and circulation. Next, history taking. Investigate the chief complaint. For unresponsive patients, seek information from family or bystanders. If no one is around, quickly determine the incidents leading up to the event. And don't forget to obtain a sample history. Next, secondary assessment. Here you get the vital signs. Significant intracranial bleeding can cause pressure in the skull, compressing the brain. So this can cause slow pulse, erratic breathing, high blood pressure, or even changes in pupil size. If the patient has altered mental status, also check the blood glucose level. All patients with an altered mental status should have a Glasgow Coma scale. Now, this scale assesses the responsiveness of eyes, your motor responsiveness, as well as your verbal responsiveness. So be sure to get that as well. Lastly, reassessment. Focus on reassessing the patient's vital signs, ABCs, and interventions. Compare previous findings with your new findings. Watch carefully for changes in pulse, blood pressure, respirations, as well as your Glasgow Coma scale scores. Notify the receiving facility about the person's chief complaint, as well as your assessment and interventions. So that was somewhat of a brief look into neurological emergencies. I hope that you enjoyed the video and that information was presented clearly for you to understand. And I also hope that you use this video as an additional resource in the midst of your studies. Thank you for your time. See you next time.